I'm going to invite our panelists up here. James Anderson is the president of the Society of PAs in Addiction Medicine and is a commissioner on the Washington State Medical Commission. He works at Evergreen Treatment Services, a federally approved opioid treatment program, and he is clinical faculty at the University of Washington Department of Family Medicine. Michelle Gaffney, she's a PA on the Addiction Consult Liaison Service at Denver Health. She also serves as Associate Director of Behavioral Health PA Fellowship at Denver Health and is an assistant professor in the Department of Psychiatry at University of Colorado. Matthew Probst is Medical Director and Chief Quality Officer of El Centro Family Health in northern New Mexico. It is a rural, federally qualified healthcare center. He is a 2003 graduate of the UNMPA program. So here's our current ethical dilemma. Patient A is a 49-year-old female. She presents with type 2 diabetes, poorly controlled hypertension, dyslipidemia, and coronary artery disease. She's been non-compliant with her diabetic diet, non-compliant with her medications. Her blood sugar today is 265, and she missed her last lab check. She's been referred to a diabetes educator, her annual eye exam, and in the past she's missed appointments. Her medications include Lantus, metformin, aspirin, rosuvastatin, lisinopril, and carvedilol. So what went wrong? What else could we do? And would we ever consider refilling her medications? Then we have patient B, also 49 years old, a male. He presents to the ED in withdrawal secondary to opioid use disorder. He has a history of several motor vehicle accidents. He has chronic low back pain as a result. He started on prescription opioids several years ago, but he was cut off. He has chronic low back pain, and he recently started heroin, first snorting, and then segued to IV drug use. He's diaphoretic, he's restless, he's yawning, complaining of body aches and nausea. You look at his PDMP and there's nothing worrisome. You get a urine drug screen and he tests only positive for morphine. You do a physical exam and you see fresh track marks on bilateral and occipital fossa. There's no abscess. Will he be prescribed anything out of the emergency department to manage his opioid use disorder? So, I'm posing this question to Michelle.
Sure.
And I'd like to ask you how you would manage this ethical dilemma.
Sure. So I can speak to what we do at Denver Health. And essentially you have two patients coming in with chronic relapsing diseases. So how we approach at Denver Health is that these two patients would receive equal treatment for their medical conditions. And for patient B specifically, we've started a program where we're starting to induct people on buprenorphine or Suboxone in the emergency department and then connect them to treatment as if they were any other patient with diabetes and refilling their diabetic medications with a PCP follow-up. So we're trying to move in the direction of treating these patients as patients with chronic relapsing diseases with a stigma-free and judgment-free environment and encouraging follow-up for ongoing management of their disease.
So I'm just going to do a follow-up question
Sure.
for you. There are settings across the country that are not as thoughtful and as advanced. And can you address those?
Sure, and I think it can be difficult. I think at Denver Health we have a lot of resources, and here in Denver we have a lot of resources where we're able to connect people to outpatient treatment. We're able to get buy-in from the university to start some of these medications, and I think if someone is practicing in a setting where they aren't as lucky with access to those resources. I think one approach that you can take when seeing a patient like this in the emergency department is just treating them like a human being and trying to understand what their current situation is that's leading them to present to the emergency department in this situation. And I think being empathetic and treating them again as an individual can be really helpful, because a lot of these patients experience stigma and judgment when they interface with the medical system, and just trying to build that therapeutic alliance to reduce some of those barriers, so that maybe even if you're not able to start medications at that instant, they may be more receptive to coming in the future when you may have access to other resources as well.
Right. So one thing that I want to follow up on is the issue of stigma, because there's a tremendous amount of stigma related to substance use disorders. And they're the only conditions where non-compliance and lapse are grounds for dismissal in many practices. And withholding treatment is considered. It would never be considered with diabetes or hypertension. And wouldn't you agree with that?
Definitely.
And sometimes medications are withheld because of personal feelings of the provider or moral objections. And active disease is actually thought to be criminal in some settings. So I'd like you, all of you, to kind of address what I just brought up in terms of stigma.
Sure. So I work in an opioid treatment program, formerly known as methadone clinics, incredibly regulated as far as what we, who we see and what we do. So in our setting, it's mostly methadone. Patients are admitted by PAs, NPs, if they meet diagnostic criteria for opiate use disorder. And that's really the easy part. But the stigma that they face and that they face their entire lives is so thick and so dense that it's sometimes overwhelming. And like you said, which I think was a good point, treating them with respect, being nice to them, it's something that many of them have never faced in their entire life. And it's really sad. But it's nice to be able to be the one to say, that must have been difficult. I mean, it's amazing what an empathy statement can do. I mean, some patients completely break into tears because they really haven't had anybody in the medical world say that, or in their whole life say that. And so it's very powerful. I think it's important to look at the complexity of what drives these stigmas, because addiction medicine is a great field for a PA. I encourage all of you to think about it. It's exploding as far as opportunities. It's a wonderful way to connect and do the things that we've been trained to do. There are so many things that I think drive stigmas. One thing is, for example, the federal rules that oversee methadone treatment. For example, until a few years ago, my clinic, if you had 9 positive UAs in a 12-month period, then you would go on a contract, which everyone would know you'd fail. You couldn't have 2 positive UAs in a month, and you'd be discharged. So you're being discharged for being sick. It's the same the way the justice system treats patients. I mean, people go to jail for many, many, many years because they're sick. And these things are changing, but there's so much to do. The medical community, I think, has come a long way. I think young PAs have really just shown me incredible wisdom as far as not having these beliefs, but it's still thick, it's still out there, and it's something that really, the stigma, I think, really keeps patients in their addiction. And it's, the good thing is there are a million ways to try to decrease it, but it's complex.
So, healthcare is a relationship, but I think, for me, being from there, that being part of who I am, the pain of where I come from, it changes the perspective. And with that perspective, what a beautiful analogy, metaphor right off the bat, that we start looking at diabetes and substance use disorder side by side, right? So y'all getting trained in diabetes in your PA programs? Raise your hands if you are not getting trained in diabetes in your PA program. University of New Mexico, now you will be trained as part of school. Deb said, I encourage you all to get trained when you get out. I encourage you all to go back to your programs and say, train me while I'm here. And even if you had never used your waiver, you should get it. Just like even if you never do rural health, you should know what it's about. And so I think it's a really important thing to look at, to understand. If that's not where you come from, that's awesome, you know. But I think with the statistics that exist now, I think you're going to be hard-pressed to find anyone in this room that it hasn't touched personally. If it's not you, it might be your family members, a friend, a community member. Raise your hand if that's the case, that addictions never touched your life personally. Right? So that changes things. So the other one I like to think of is cancer, right? Because to be a survivor of cancer, we wear pink ribbons, and it's like a badge of honor. And I think recovery, that's the opposite side of the stigma that I would like us to talk about. When you see someone that's in recovery, when they are truly in recovery, they are unbreakable. They are so strong and so amazing. And so encouraging folks that aren't quite there yet to say, you can do this, and this is what you can become. And when we as a society can look at it that way and say, yeah, you're a productive member of society, you are so resilient, you've overcome so much, I think we're going to give this country a fighting chance.
Thank you. So we're going to look at an instructional video that was produced by NIDA. And I think you're going to find some interesting perspective here.
Hi, Mr. Davis. I'm Dr. Pantelis.
Yeah, look, I need to get out of here. This is ridiculous. I fell asleep in the park, and now I'm here. I did not need the Narcan, all right? I just don't understand why I'm here.
No, this is one big surprise to you.
Exactly.
Yeah, no, it must be scary, waking up, being in an ambulance.
Damn straight.
Okay, well, let's see if we can take care of you here as quickly as possible. Would that be okay?
Yeah, fine. Let's just hurry it up, okay?
Do you mind if we talk about your use of heroin for a few
Oh,
minutes?
here we go. Yeah, fine. You know, if it'll get me out of here quicker.
I appreciate that. No, I do. But tell me, what happened tonight? Why do you think people were...
Look, I used some heroin, okay?
Anything different? Why do you think people were worried about you?
I don't know. How am I supposed to know?
Okay, well, apparently they were unable to wake you. They thought you'd stop breathing.
I took some other stuff, like some Xanax and some stuff a friend had. I don't know.
Well, that may have been it. Did you use the same amount of heroin you usually do?
Look, I know what I'm doing, okay? I've been doing this for a while.
Well, I mean, but these days, no one really knows what they're buying off the street. And when you're combining heroin with other sedatives like Valium, Xanax, Klonopin, you greatly increase the risk of overdosing. I mean, you know that they both affect your breathing.
Look, I know that I am an addict, all right? What do you want? I just need to get my stuff, all right? Everyone's got to die of something.
So, this is for all three of you. How does substance use disorder usually present itself in your practice? And what does the road to addiction look like for your patients? There's been a lot of attention on opioids lately, but are there other substances that you see frequently or are on the rise?
Well, for me, it's sort of simple because I work in an opioid use disorder. I mean, we treat opioid use. And so many of our patients have other things. Well, most of them have other things too. Most of them also have benzodiazepine or alcohol use. And also, one thing I think that we often forget about is tobacco. When we think about these issues, people present to me because they are usually addicted to heroin, and that diagnosis is usually not a difficult one to make, but then the complexity does become as far as treating the other things as well. I think this film showed a really wonderful use of motivational interviewing by the provider. I mean, just really skillful. And still, it was difficult for him to connect with the patient, but that was like a clinic on how to treat a patient like that.
So I work in a hospital on an addictions consult service. So I see patients who are admitted to the hospital on medical services, ortho or surgery services, and then primary services usually identify either a concern that they're maybe consciously aware of or just some problem behavior that they may not have a true question of what's going on, but they know that like addiction is playing a role somehow, and they just need some assistance. And they'll put in a consult, and myself or my colleague will come in and chat with the patient. I was actually hired about 3 years ago specifically to provide MAT in the hospital setting, so starting patients on methadone or Suboxone and then connecting them to outpatient treatment. Because we found that we're seeing a lot of patients coming into the hospital with either abscesses, osteomyelitis, endocarditis, or even after an overdose from their opioid use. And what an ideal time to start medications and connect people to treatment when they've kind of seen maybe the highest level of medical complications that they may experience from their ongoing IV drug use. So that was my purpose, but really right now here in Denver, we're seeing an increase in methamphetamine use, and I think that's pretty prevalent in the West, and I think even the East Coast is starting to see that as well. I work at a safety net hospital, so a lot of our patients are currently homeless, and for a lot of our patients, methamphetamine is kind of a means of survival, being able to stay up during the night so that they can protect each other, protect themselves. So it's very difficult to kind of disentangle the substance use from purely survival and almost necessity for some people. So for a lot of the patients that I see, it's really kind of chatting about trying to understand what the underlying kind of drive for their substance use is. And even though I might not be able to offer a medication or get them into some sort of substance treatment, try to offer maybe some alternative thoughts about what may be helpful to change some of those behaviors or some of those root causes that may be driving the substance use. I encounter patients that are ambivalent, pre-contemplative all the time, and just trying to have a conversation and try to open that door so that maybe next time they may be more willing to chat more about their substance use or may be more willing to engage. So I see patients kind of all along the spectrum. Unfortunately, I don't see many patients in recovery, which would be great at some point. I usually see patients when they are in crisis, but it's very rewarding seeing patients kind of turn their thought process and even their behaviors around pretty quickly in the hospital. And I think this field is probably one of the most rewarding fields you can work in as a PA. It's quite satisfying.
Treating addiction is primary care, and if it wasn't in rural America, we'd have a major issue because we don't have specialty clinics. So access to care, it's got to be a primary care issue, and in terms of equity, the most recent study out now out of the University of Michigan talks a lot about that, and I think that's a really important thing. So you look at it like any chronic illness. So, it presents itself back to diabetes. So you've got, what are we looking out for? Are we waiting until their A1C is 14, guys? We're trying to catch it as pre-diabetes, right? Actually, we're trying to prevent pre-diabetes, right? By teaching kids how to eat well and develop their taste buds to like veggies and how to exercise and make healthy choices. It's the same perspective. That's my perspective. But that's where we make the biggest difference. In community medicine, in our federally qualified health centers and community medicine, that's where we've put the most investment over recent years. But as Deb said, in New Mexico, we made a 0.4% difference doing that. So we decreased overdose drug death rates by 0.4%. I'm not satisfied with that. We went, and now we're 17th, actually, with the most recent data out there as a state, not because we've gotten so much better, 0.4% better, because everyone else is getting worse much quicker. And I want to see a 50% difference. And so that's why investing in our youth and trying to catch it way upstream, to me, is the best approach. Don't get me wrong, we still need treatment as well. But that, to me, is a really important thing. And I think back to other drugs, it's whack-a-mole. So you try and whack that one, and next thing you know, meth's popping up or whatever. Now in New Mexico, we have alprazolam in terms of prescription drug overdose deaths has now surpassed the prescription opioids. That just recently happened, and it's about access and what can you get. And so that is, so again, back to a prevention strategy is teaching people to make better choices and to try to not get there in the first place, if at all possible. And again, chronic illness, we think about that with substance use disorder, but it is now the acute illness with, unfortunately, with fentanyl. So, yeah, deaths from chronic illnesses growing up, that's the way that I looked at it, and that's how I saw it early in my practice. But now with fentanyl, and anything can be laced with fentanyl, pot, anything. You know, it can be in any pill, using pill crushers. It just takes once. And so, particularly with youth, seeing folks die at a young age from fentanyl overdose deaths, to me, that's a really important thing to prevent.
All right, we're going to move on to the next question. And this, again, is for anyone. What about the co-occurrence of alcohol use disorder in your patients? Many places aren't necessarily checking for alcohol and are still, for example, distributing pain medication. And I'll just start by saying I worked several years ago in a pain practice. And when I went in there, I was kind of astonished at how many patients were coming in getting chronic opioid therapy and drinking alcohol and thinking nothing of it. So I did a lot of education around this. We unfortunately had to segue some patients out of the practice and get them into other types of treatment because they ended up having the DSM-5 criteria for an alcohol use disorder. Some of them were not very happy about it, and we had to get family involved in order to get them to realize that, you know, this was dangerous to be drinking and using chronic pain medications. So I'll open this up to the panel.
It's a huge problem where I work in an opioid treatment program. It's easy for us to get so focused on heroin and sort of miss the other things. And it is sort of like whack-a-mole. That was a great analogy. It's like, oh, now he has a positive for benzos. So we do, in methadone, the patient goes to the dispensary every day and the medication is dispensed in opiate treatment programs. It's not prescribed. The PAs, NPs, we order the dispensation of the methadone. It's dispensed in a dispensary, and one good thing about that is the patients do that 6 days a week when they start, which is really demanding for patients who sometimes are not able to navigate a complex system. But for those who do, they see a nurse. The nurse assesses them, you know, in a matter of 30 seconds. How do they look? How do they sound? Are they safe to prescribe? Safe to give them methadone? And if people appear impaired, then we'll breathalyze them. But one of the challenges is that many of our patients have such high tolerance for alcohol that they can blow a .20 and they can look great. Really, really crisp, you know, clear eyes, how you doing, no staggering, no slurring. That's not always the case, but it can be the case. And so that makes it even tougher because standard screenings that you would do are difficult. So it's a big challenge for us. And sometimes I think we miss the forest for the trees, but we try and see them both.
I would say a majority of the patients that I see in the hospital are for alcohol use disorder. Alcohol affects every organ in the human body, so you can see a wide variety of medical complications from severe alcohol use disorder. There's medications that can help with alcohol use disorder. So one that I most commonly prescribe is naltrexone, which is a mu receptor antagonist and helps block some of the cravings for alcohol. It also comes in an intramuscular 1-month injectable form called Vivitrol. And I've had some patients have long-term recovery with both of those medications. It's tough though, because I think alcohol is so integrated into our society and socialization that I find that especially for our young patients, they become very isolated when they enter recovery. So again, kind of thinking of the patient holistically and thinking of the different behaviors, the different psychosocial factors that might be contributing to their addiction is really important for sustained long-term recovery. But alcohol use disorder is definitely overlooked within the medical community.
So we're going to move on to the next film segment, seeing the same provider with the same patient. Let's see how he does.
Now, we have treatments for this.
What, you mean like that methadone stuff? You know, I've had friends that have taken that, and it makes them feel worse. And I know that it rots your teeth.
No, methadone does not rot your teeth. That's a myth. But you are right. We're talking about appropriate medications for the treatment of addiction, like methadone, buprenorphine, commonly known as Suboxone. They help many people. They're highly effective. They help people get on with their lives, get jobs, have productive relationships.
Yeah, okay. Well, you know, I do have a job. I take care of the apartment buildings near here, and I do just fine.
Well, that's great. It's good to know that you function well when you get there, if you get there. But frankly, I'm worried you may have another overdose.
And I'm telling you, I am an addict. I do not care.
Well, let me tell you something. For myself, I don't even use words like addict. I think they're stigmatizing and harmful. You have an addiction, or more accurately, an opioid use disorder. You didn't create it. You didn't bring it on yourself. But you do play a big role in changing it if you want. But that's totally up to you. I can't force you.
Yeah, well, I wish there were more people in the world that felt that way. You know, I just feel like I've been trying to get myself out of this hole forever.
I'm sorry, I get that. But it sounds like you're saying people just don't understand what you're struggling with. And that you can't manage it alone.
So, another question for Michelle. How do you tackle resistance from patients who don't want to discuss their substance use at all once you're called for a consult?
So I think kind of the biggest piece of advice or kind of the strategy that I have when someone may be ambivalent or pre-contemplative or maybe not have any insight into their substance use and how that's negatively affecting them is to try to just listen to what concerns they do have, validate a lot of the concerns that they may have or difficulties that they're having, and try to find some sort of little hook of ambivalence to maybe kind of drag them across and highlight, okay, I hear you're telling me that you're spending X amount of money on your heroin a day, but you would like to actually be spending it here. Let's kind of talk about this and how we may be able to kind of change their thought process on their substance use. Sometimes it doesn't happen. And then it's just, again, kind of treating that person as an individual and a human being so that maybe in the future when they represent, they may be more willing to engage and discuss their substance use disorder. If someone is very resistant, I always go back to harm reduction counseling, talking about clean needle exchanges, clean needle use, using in groups, having Narcan so that if someone does overdose, they're able to revive, talk about the Good Samaritan law. So here in Colorado, and I think most states in the country have a Good Samaritan law where although the Narcan is prescribed to an individual, if they come across anyone who has overdosed on opioids, they can use that medication to revive the person. And then if they have any drug paraphernalia or substance on person, they can call 911 and they are protected against any ticketing or any legal consequences. So I always try to kind of meet them where they're at and then do counseling, try to provide as much information as possible so that person's able to make an informed decision about either their substance use or their treatment moving forward.
So for Jim, you're working with MAT every day. How do you assess for and have conversations around patient readiness for this kind of treatment? Have you experienced stigma around MAT from patients, providers, or family? And can you talk about how that stigma can affect providers as well as patients?
Sure. Yes. Stigma, as I noted before, is just so ever present, and it just sort of fills the room sometime. And it's almost like you can smell it. And patients the question about families, most of my patients, I don't know, I'm guessing, but I would say the majority of my patients, they don't have any family who will even talk to them. I mean, let alone come to treatment with them or let them go through the diagnosis. They really, many of them have absolutely nothing. You know, they sleep outside in the dirt. They can barely come to the clinic. They don't bathe. That's not always the case. We have many cases who do really well. Matter of fact, 70% of the patients that are where I work each month have negative UAs, and it's fun to work with the patients who are stable. But the ones that really are the demanding ones are the ones who are doing poorly. So trying to do motivational interviewing, trying to empathize, trying to sometimes redirect them when they say really terrible things about themselves, like I'm worthless. I know I'm worthless. Nobody gives a shit about me, and I don't either, and I'm worthless. And that's a really sad thing to hear somebody say. And it's also something that's probably going to contribute to them staying in their addiction. So empathizing, trying to throw out the occasional empathetic statement, motivation interviewing. If they're resistant, working around it. One of the key principles of motivational addiction, roll with resistance. If they're like, you don't understand, then like just, okay, I'll find something else to try to connect with. And that's what I do, but it's a daily challenge. But it's one of the really exciting things about being in this field is when you do it well.
Now we're going to watch the third film clip.
Well, how ready might you be to make any change in your drug use?
What do you mean?
Well, for example, not using sedatives if you choose to use heroin.
Yeah, I guess I could do that.
All right, so it's good to know that's possible. I appreciate that. But why would you want to do that? What would be in it for you to take the sedatives out of the
Well,
picture?
I don't want to go through this again.
Okay. All right, that's good. So you don't want to die. You have an addiction, you're acknowledging that. You plan perhaps to continue using heroin, but you know you have to change how you use it.
Yeah, I guess you're right. Now, really, I'd like to get
Okay.
going.
I can't stop you from doing that, but we'll get you some phone numbers, okay? So if you want to continue this kind of conversation with someone else, another counselor, you'll be able to do that, okay? And we'll also have the nurse come in with an naloxone kit for you so you can reverse if you have another overdose, and she'll give you some instructions with that.
Okay, but what good is that going to do me when I'm the one in trouble?
Well, if you're alone, you're right, it may not help. But we tell everyone, if you're going to choose to use again, the worst thing you can do is to use alone. So use with others, let them know you have the kit on you, and who knows, you may need to use it on them, or they might use it on you.
Okay, thanks, I got it. Now, really, I need to go or I will lose my job.
Okay, we understand. The nurse is here. She'll give you those instructions, and remember, you can always come back here. Thank you for your time.
Thank you.
Hi, Mr. Davis. My name's Casey. I'm the nurse. I'm going to go over your naloxone kit, okay?
All right.
All right.
Okay, question for Matt. Due in part to provider shortages, there has been a recent push to integrate substance use disorder treatment into primary care. How long have you been treating or working around substance use disorders, and what do you think the impact is of having it integrated with primary care? I know you talked about this a little bit, but maybe you can address it a little bit more.
So, and this kind of goes back to stigma and motivational interviewing, and some of the things mentioned with the last question is that, so in community health and primary care, healthcare is a relationship. You get to know your patients over the long term, and so I think it's a great place to be able to engage patients, whether it's about whatever the issue is, including issues within substance use disorder. When you have patients that aren't there yet, maybe they're pre-contemplative, you've got time, so you don't have to do it while they're hospitalized. You can continue that process. And actually, I would say for the work that I love to do in terms of prevention and youth medicine, again, it's creating a new normal, because back to our counties, it's normal. It's normal to grow up using substances. And so how do you create a new normal? That's with our youth. I love that clip there. So, one of our most recent initiatives is, so we use peer health educators a lot. We have school-based health centers. And so in every one of our school-based health centers, we use peer health educators, and now we teach them in different areas, including this area. We teach them in harm reduction, and so we have Narcan training for our peer health educators. And so you're engaging it from all of these different perspectives, and so I think that it's a different perspective in primary care. Primary care is a team sport, and so that concept, peer health educators are part of that team sport. Community health workers are part of that team sport. Primary care providers, behavioral health therapists, peer support specialists, LSAAs, LADACs, LISWs, and I love team sports. So the more people that are getting involved, and I would say that even beyond that in primary care, you get to a point, and I think that Deb could talk a lot about this, this would be a whole nother session, but is that you have to extend beyond the boundaries of saying you're in the clinic and you're a health professional, because law enforcement are part of this. Our police officers carry Narcan, and thinking about law enforcement assisted diversion and getting people a treatment instead of incarceration, they're part of this. Judges are part of this. Business people, family members, clergy, everyone's a part of this. For us, again, and I say a fighting chance, because if this wasn't a war, then why are so many people dying? And for us to have a fighting chance, it can't just, don't get me wrong, specialists have a huge role to play, but it can't just be specialists, and it can't even just be health professionals. It has to be all of us. And so I think primary care gives us a setting and an advantage. And back to the recent article, that was one of, it's saying that the fix must include universal access to treatment in a primary care setting. It's not the only fix, but it's definitely a part of the fix.
So this is just for anyone. How do you see substance use disorders affecting other aspects of patient health? And what role does the provider play in addressing all of these impacts?
One quick thing I could say is that in my work, the patients who do the best are the patients who are able to embrace a recovery model. They engage in the counseling at our clinic. They take care of their physical problems. They engage in the mental health community. These are the patients that do well. And so when I meet with patients, particularly when they come in and just start, I really try and share that with them. And if they're motivated, I want them to say, if you're going to do well, you do best if you can do mental health, physical health. This is really where you want to go.
So back to our diabetes analogy. So you wouldn't just say, your A1C is 14, here's your insulin, see you in 3 months. Would you? That's not how you learned it, right? So we got to do all kinds of stuff. And so education is a huge part for overcoming substance use disorder. For us, we use a matrix model. And so it really is. We try and tell our patients with diabetes, you're going to have to learn everything you can about managing your chronic illness for the rest of your life. Well, the same thing with substance use disorder. So, and back to that, so matrix model includes exercise and meditation and diet and all kinds of things that we do as part of that approach, the same way we would with diabetes. And I agree that is a huge part of the success. And those other components, I think, this was said earlier too, patients feel bad about themselves already. Whether diabetes is uncontrolled, and that stigma of feeling like they're failing, or their substance use disorder is uncontrolled, and trying to make them feel worse about it doesn't help. You're giving them the tools to be successful. And back to the work that Deb does, that's a job. If you don't have a job, and if you don't have money in your pocket, it's hard to think about your uncontrolled diabetes or your substance use disorder. If you don't have transportation, if you don't have housing, those components. So, I think they're back to that trauma-informed care, right? And when folks are there, giving those opportunities to succeed.
So I'll just comment on that, because my patient population are people who probably have spent more time in jail or prison than out. Most of them have never seen a healthcare provider outside of a criminal justice setting. So when they come to me, they don't have insurance. They lose that when they're incarcerated. And they haven't had a shower. They're coming right from a criminal justice setting. So obviously they don't have a job. They don't have transportation. They don't have a home. They have no medication. And they're stuck. They feel like their disease is a moral failing because they've been told that their whole life. So we are starting at ground zero and just building them up and working their way up. We offer mindfulness meditation, yoga, individual counseling, group counseling. We hold them like this, like they're in a cradle. And they go step by step by step. And if they relapse, they don't go back to jail. We realize that this is a chronic disease, and we talk to them about that, and we say to them, you used and you stopped. Good for you. You realize that this was not the answer. Why? What made you stop? And this is what works. So we looked at recidivism rates from 2017 to 2018. Most criminal justice settings, drug courts, recidivism rates will run from 30 to 70%. Our recidivism rate was 12%. People are successful. Why? Because we hold them like they're in a cradle. We take them one step at a time. We meet them where they're at. We make sure 3 months out of graduating that they are hooked up with primary care, so that whatever medications that they're treated with are continued. Other diseases that they may have, we get labs early on. So if they have thyroid disease, diabetes, hepatitis C, we send them to specialists so they can be treated. They see that we care. We don't use stigmatizing language that they've heard their whole life. We don't use things like they're dirty for a substance. I have actually flashcards in the office, and as soon as they use that, I say, you're positive for a substance, not dirty. We turn that all around. We turn it on its head. So, you know, we're changing lives. We're saving lives. There's nothing that's more rewarding than addiction medicine, and Jim has already said that. So we're going to move on. Question for Michelle. Especially in the light of the way substance use disorders impact different areas of a patient's life, what do you see as the role of harm reduction in combating substance use disorders, and specifically the opioid epidemic? Are there barriers to treatment for different patient populations that may make harm reduction strategies more effective? And I know you talked about this a little bit.
Yeah, I kind of jumped the gun on that a little bit, but I love talking about harm reduction. So I think harm reduction is essential in kind of the treatment continuum. So as we've kind of discussed before, you'll meet patients who aren't ready for treatment. They're not ready for that lifestyle change. So keeping them alive until they get there is essential to getting them into long-term recovery. So again, talking about if they're using IV drugs, using in a group, so that if someone overdoses, they then hopefully have Narcan, and encouraging multiple doses of Narcan in that group, because we are seeing a lot more fentanyl in the streets, and that usually takes 3, 4, 5 hits of Narcan to reverse that overdose. Talking about clean needle exchanges, we're seeing an increase in hepatitis C, hepatitis B, HIV here in Colorado. So talking about connecting with our clean needle exchange organizations in the community, not reusing needles, not sharing needles to try to decrease those infectious disease spread rates. So there are a lot of different things that you can chat with, and then again, that's creating a therapeutic alliance with that patient. It's meeting where they're at, instead of taking the more paternalistic approach and telling someone, you should be doing this, because they've been hearing that their entire life. So meeting them where they're at, having a real conversation to then keep that door open so that in the future, when they represent, they're able to maybe engage. And if not, then the harm reduction counseling continues until they open that door and engage.
Debbie, can I say one thing about that? My supervising physician is really great, a hilarious guy, very supportive. But he's also, he likes to challenge us on our beliefs. He's been in the field forever. He's one of the most progressive MDs I know, but he really hates it. I've always had the beliefs you have about harm reduction, but he hates harm reduction. And he says, you know, it's treatment. It's like, why don't we just say this is treatment? And whether it's counseling and trying to get people to use less needles, it just bugs him that he sees it as a sort of a statement about the stigma of heroin use and substance use disorder, is why can't we just call this treatment? And I think that's kind of funny. I still believe everything you just said,
Yeah,
too.
it's kind of like treatment for pre-contemplation.
Yeah, exactly.
And then another thing that we like to counsel patients on too is the danger of using substances concurrently, especially opioids with benzos and alcohol. So just providing some of that information and that education so people can make hopefully more healthy decisions.
So question for Jim. So let's continue to discuss continuity of care. How do you follow up with patients, connect them to additional resources, and how does patient readiness impact this?
Well, actually, we end up being the place that people send people, ideally, from the hospital. So there's hub and spoke. Hub is the hospital. Spoke is where do you send them after that? Well, so we're kind of a spoke. We're a place that hospitals send patients who are identified with opiate use disorder, and they start on methadone in the hospital, and then they come to us. Best case scenario, that's how it works. And we know that the patients who live the longest are patients staying in methadone treatment the longest. So our goal is not to get them out. Our goal is to keep them in treatment as long as we possibly can. It's not jail, but we know that they'll live longer that way.
There's actually an interesting statistic that when people are engaged in treatment in MAT, After the first year, their treatment success rate is about a third, about 36%. After 3 years, if they stay in treatment, it goes up to about 2/3, about 66%. But after 5 years, it's close to 90%. So what that means is if someone can stay engaged in treatment, that means that there's a less than 15% relapse rate. I mean, consider that. So in terms of the whole primary care model, if you have this great therapeutic relationship, you're not going to have overdose deaths. You're going to have people engaged in treatment and all aspects of treatment, not just the treatment of substance use disorders. So that's an important fact that everybody should remember. Okay, so Jim, again, what does success look like for your patients? And how does the cycle of relapse and recovery work at your OTP?
Sure. Well, success looks like not dying, really, in a nutshell. That's our number one goal, is to have as few of our patients die as possible, which is really what medicine is about, right? I mean, in its most basic. I mean, it's way broader than that. But that's our goal. Our goal is, and we know that if they stay in treatment, even if they continue to use some drugs, they're less likely to die. And so that's our goal, is to keep them in treatment as long as possible, as long as they're engaged, and to keep them on the right side of the earth.